And welcome, everyone. I just wanted to say hello, and I'm looking forward to this opportunity. I'm going to go ahead and get off the screen in order to save bandwidth. So as this is a new reality these days that we live with. So today's presentation has grown out of really some conversations that we have been having at Pearson, just about kind of what the field is experiencing and dealing with as our society is going through a variety of changes, and I think adopting a new level of tolerance for activities and behaviors that have historically been considered illegal, and then still are at the federal level, in fact. So we are, interestingly enough, in a very curious time. So the idea here of talking about substance use, which, as we are aware, is becoming more and more available, how does that impact our mental health care in our mental health care industry, and what is a new normal? So today is we have 90 minutes. I think we may use the whole time, maybe not, to kind of see how the pace goes. But this is really designed not to be a comprehensive review of research and whatnot. It's more of a conversation out of our grand rounds discussions that we've been having. So as we all know, our societal attitudes are in flux about historically legal substance use, and I say this is in a dynamic state of change, and the dynamics really are an opening up of not only availability and acceptance, but even as we are hearing more and more, significant high level of research on the application of some of these substances that are controlled substances. So as noted, we're going to be focusing not on alcohol so much, as we know alcohol is legal, but even so, it's long been a substance of concern. It has lots of research behind what it does to the body, the mind, our social systems that we find ourselves in, whether it's family or work, and alcohol treatment, as well as substance use treatment. If you are not familiar with that field, really looks at use behavior as a biopsychosocial model, and when they try to do interventions. But as we talk about the lay of the land, California was the first state to allow medical cannabis use laws back in 1996. And that really opened the door for other states to be considering. We've really kind of seen a wave from the West Coast and then the upper eastern regions of the country, where some of them are early adopting states for medical marijuana. And I remember back in the late 90s when I was running some youth addiction treatment programs, and also working with some of the Native American community in the Portland, Oregon region, is that this issue of medical marijuana really became a problem for many of the substance abuse treatment agencies, because they basically would see folks who would be referred for, let's say, a DUI for treatment, and they weren't supposed to use alcohol, yet they were now able to legally use cannabis. And many treatment agencies, most of them actually, had a no-use requirement in order to be getting care there. And so it really became a quandary at the time for how do you do this? How do you have conjoint groups, or do you have to separate them out? And they'd written an article for the local, the regional addictions treatment agency, and or for the state organization, about having to split basically your communities initially just to get until we got a handle on things. But anyways, so since then, the overall acceptance of medical cannabis use, particularly, has expanded to 33 states in the District of Columbia, and these are for the medical cannabis laws. And I believe there's 11 states currently that have recreational cannabis laws, which in most of these states followed within 5 to 6 years after the medical cannabis laws were allowed or created. So this decriminalization at the state level of cannabis, which is still considered a Schedule I narcotic in the federal level, is likely the total decriminalization, so we hear, is likely to occur under the Biden-Harris administration, based on some of the statements they had made prior to the recent election. So we can really see, we're really going to continue to see this normalization and access as a result of that normalization to cannabis and cannabis-related products in our society, in our communities. So, and since then, since it has opened up in many of these states, is that they've seen a skyrocket in most of those of use and access, really. Clearly, if they're accessing it, they're using it. But where you just have a kind of a growing, maybe proliferation is too strong of a word, but you have dispensaries that are available throughout most of these states. There are some exceptions where some communities have said that they do not, they would not certify certain dispensaries to be within their jurisdictions, but that will probably very likely change as things become normalized nationally. So as mental health professionals, what we are already saying, actually, and probably expecting to see more of, is that you will have folks who you're working with who have certain, they'll have an acceptance and have normalized their own consumption, and that may or may not be complicating the mental health problem. So it's a whole layer now that we really need to be aware of more actively as we work with our client populations. So additionally, as you've probably been reading in not only scientific journals, but it's been making its way into some of the public dissemination, is that there's also growing interest in the reassessment, frankly, of research of what I describe as the psychedelic experience-inducing substances, and coupled with psychotherapy in order to treat some fairly entrenched or treatment non-responsive conditions of PTSD, depression, anxiety, and the addictions, particularly some of the prior research that had been done on alcoholism and whatnot. And these types of treatments, in some degree, have been available in other countries, but they hadn't consistently been looked at with the rigor of the scientific method, which has started to change. And as you know, we are generally seeing positive results for the inclusion of these types of experience-inducing substances, psychedelic experience-inducing substances, on how people are reprocessing and re-entering into their healing process and getting some positive results. So in my neck of the woods over here in Oregon, it will be the first state in the United States to allow psilocybin-assisted therapy for treatment of certain mental health disorders. That'll be effective in about 2 years. And so Oregon will be setting the stage for ramping up and figuring out the regulations on how to do all that, and following the guidelines that have been established by some of the research studies that are currently out there. Curiously enough, this isn't just to talk about cannabis and psilocybin or psychedelic therapies, but substance use in general is getting a higher level of tolerance within the country. And Oregon, again, was the first state, statewide at least, to pass legislation that decriminalized all drugs in small or personal use amounts, similar to what we have seen in countries like Portugal, over in Europe, and some others, where people who may get cited for actually using substances will have a choice to pay a nominal fine of, $100, or be referred for an alcohol and drug evaluation. And the nice thing about this Oregon law, or one of the arguments behind it, is that money that normally would be invested in criminal intervention or intervention of criminal activity will actually be diverted for treatment. And so there's a real shift away from seeing kind of the frank use of illicit substances as a criminal activity, and more as a public health problem that involves addiction and self-destructive behaviors. So we'll probably continue to see this trend develop. I think it's started in some regions. I think Denver decriminalized at least the psychedelic class of drugs a couple of years ago within the city limits, and then Santa Cruz, I think last year, was another city that decriminalized it. So, and then Oregon has done so as a state. So it'll be curious to see how that unfolds, and hopefully we'll have some good data that gets collected regarding its the effect that legislation has on the public health perception of using those resources to treat folks. So to kind of focus a little bit more on some of the novel stuff that's occurring in the psychedelic world, assisted therapy world, is that we are seeing recent studies that show positive short-term and sustained effects at follow-up. These have all typically had smaller sample sizes and are limited predominantly to Caucasian groups, and also often will include subjects that have had prior experiences of substance use, and particularly these categories of substances. So, as the work continues to unfold, they're doing more and more with kind of larger sample sizes, more heterogeneous sampling groups, and so it'll be interesting to see how things unfold. Also, funding for research in this arena has occurred both nationally within the United States, and a large amount of it has been through international efforts, and is growing for the examining of the efficacy of these types of therapies for kind of broader mental health conditions. In the recent scientific literature, it's looked at 4 mental health conditions so far in several multiple controlled, double-blind, placebo-conditioned studies that have a good amount of scientific rigor. And these conditions so far have included post-traumatic stress disorder, anxiety and depression, particularly associated with life-threatening illnesses. So you may be aware that some of the research was around folks who've been diagnosed with terminal cancer or stage 4 cancer, and then just a lot of the anxiety around these end-of-life expectations. And then also with unipolar depression and social anxiety among autistic adults. And recently, King's College, I think it was King's College in England, has gotten clearance to do another depression study with one of the more potent forms of these substances known as DMT. So interesting stuff happening. So Schedule I psychedelic drugs used in recent controlled studies include psilocybin, also LSD, ayahuasca, which is kind of a ceremonial tea that's generated and used in South America, but it's also one of the precursor elements of that is DMT, which is also used and created through a variety of different mechanisms, not necessarily requiring the ayahuasca. As you are probably aware, there are ketamine treatments have been in use for some time, particularly for intractable depression, which involves a series of infusions over the course of multiple weeks. And then the MDMA assisted therapies as well. If you're not familiar with MDMA, it's also known as a street drug, as ecstasy. You may hear about it as Molly, some slang terminology and so on. But MDMA, the pharmaceutical MDMA, has been applied to a series of studies also with positive results. So some really interesting trends to keep to be aware of as things continue to unfold. So even though social acceptance of medical and recreational substance use is growing, co-occurring substance abuse still remains a concern. And as practitioners in the field, this is something that we want to be much more aware of, and because you are going to be seeing more substance use in general in your population than maybe you might have in the past, or they're just telling you about it more because it's more normalized than maybe they would have in the past. So it still remains, though, a concern for vulnerable mental health populations and other at-risk groups. And so we can talk a little about some of that. So this is something I've talked about before. The data is getting a little bit dated, but it It holds steady. So when you look at the prevalence of co-occurring substance use disorders and independent mood, anxiety, and personality disorders, what we see is that as you kind of look down through the various diagnostic categories for mood, anxiety, and at the bottom here, personality disorders, is that we see a very high level of co-occurrence. So when we look at all mood disorders, about 1 in 5 people report a lifetime prevalence of substance use who struggle with that, and 17% of all mood disorders report. 70% of that population report alcohol abuse as well. So, excuse me. So as you can see that as we kind of look through the lifetime reported prevalence of kind of co-occurring substance use across these various mental health conditions, the level is strikingly high. And this is from JAMA, 2004 data. But when we look at personality disorders, this is also a striking number that over the course of their lifetime, almost half have report problematic substance use at some period of their life. So these are significant numbers. And then NIH in 2006 published a 12-month prevalence of mood and anxiety disorders with and without substance use. And when we look at the NIH study in that 12-month window, we also see high numbers of substance use involved behaviors, okay, that co-occur with these mood disorders. Now, the prior slide, the numbers were higher in that prior slide. For example, all mood disorders is 20%. What we see here is 9%. But the difference is this is really looking at a 12-month window versus a lifetime prevalence. And so what this tells us is that even in kind of a narrower window of time, there's a high probability that 10% of your population that you're seeing who has a mood disorder or anxiety disorder is going to be having some substance use involvement. Okay. And then, so this slide represents data reported from respondents who actually did have a diagnosable 12-month substance use disorder. So we see that that number jumps. So if you have a diagnosed substance use disorder, the prevalence of co-occurring mental health problems is consistent with that lifetime prevalence reported number. So we see that people who have substance use typically are also suffering, many of them, at least 1 in 5, are suffering from co-occurring mental health problems, okay? Whereas when we look at folks who have predominantly mental health problems without a substance use disorder that's diagnosable, we see that those numbers drop back to that same 12-month window. So at the end of the day, the news is that we are going to see folks who have these kinds of behaviors, particularly when we're dealing with the predominant mental health issues of depression and anxiety. And indeed, if you're working with personality disorder individuals, you can anticipate that there's going to be something involved for many of them, probably up to close to half of them. So, given that these emerging tolerance as a new normal that we have this emerging tolerance of substance use, let's talk a little bit about what a substance use disorder is, okay? Because this is where our thresholds of diagnosis and our knowledge is going to become helpful. So first of all, from the DSM, it involves taking a substance in larger amounts or for longer periods of time than intended. So this is the idea where you have one drink, think you're not going to have any more, or maybe you have one hit of a cannabis pipe, and then next thing you know, you're off and running. You can't stop. You want more and more, or you end up using for longer periods of time, with not the intention of initially wanting to do that when you started, but it's now the train is rolling and you're on it. Efforts to cut down or stop using the substance, but then not being able to successfully do that and manage it. So there are generally 3 groups of folks who have diagnosable substance use disorders, or who we can kind of differentiate these 3 groups. and I think this is related to the work of Michael White, had done research around this. But the first group are those who have, when they use, they cannot control it. It very quickly descends out of control. And for those folks, typically what is required over the course of their use lifetime is that they're going to probably only be able to become clean and sober through treatment. That might involve intensive residential treatment, but abstinence really has to be their goal, because moderation is just not something that they can do. Okay. Then there's another third who develop substance abuse disorders, excuse me, who really are seeming to manifest that use behavior secondary to some other developmental traumas or mental health issues such as PTSD or depression and anxiety. And that group would really be captured in some of those population representative samples I was showing earlier. Okay. And then what we find is that when those groups become stable in their mental health concerns or issues, is that the substance use, the lack of control of their substance use dissipates. And so this group of individuals, why we would benefit from a full abstinence lifestyle, may be able to actually use alcohol and some other substances with moderation and without losing control moving ahead. But there's never 100% guarantee that. And then there is a third group, which are individuals who develop the substance abuse behaviors, typically tend to be younger, late adolescence, early adulthood, college age, you could say, whose behavior would meet all the criteria of having a diagnostic condition. But those behaviors begin to become incompatible with responsibilities of life. So the lifestyle doesn't jive with how they basically need to live their life. And so they discontinue excessive use or uncontrolled use, moderate themselves, maybe stop using, but they, in essence, kind of mature out of it. They grow out of it. And so those last two groups are going to be, I think, less susceptible to the rampant uncontrolled use that you would see with that first group. And so, and many of those, and those second two groups may be the folks who come to you in your outpatient mental health clinics and practices. So the third criteria is spending a lot of time getting, using, and recovering from use of substances. And I thought about kind of bolding this one a little bit, because what we're finding is that the activity isn't like people aren't spending as much time and activity, partly because it's more available. And if you're on the far end of the spectrum where you're really a heavy user, it's also highly available. People know how to get it, they know where to get it. And so in some ways, that third criteria is becoming less of a factor loading, I think, in this diagnostic criteria. And then there's the cravings and urges to use when the substance, particularly when the substance isn't there. And so that really becomes a driver of the behavior. And this is significantly more so with substances of the opioid class, and like methamphetamine and so on. Not managing to do what you should at work, home, or school because of substance use, so your responsibilities begin to falter. Then they continue to use the substance even when it's causing problems in relationships, whether that's marital, other family relationships, children, and so on. The giving up of important social, occupational, and recreational activities because of the substance. So the substance really the focus on the substance really becomes the kind of the primary where the primary energy is going. And so those other compensatory life behaviors that are also good for us tend to falter and go by the wayside more and more. And then continuing to use substances again and again, even when it puts you in danger of risk or harm. For example, using while you're driving. If you're a truck driver and you're using, you can't be drinking, you can't be smoking cannabis, you can't be doing methamphetamines, and yet they continue to do that knowing that they're at increased risk for losing their jobs or putting people in danger. Continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. I'm thinking of one example of a person I was working with who was doing a lot of LSD and other psychedelic mushrooms and doing ecstasy, MDMA, and then basically couldn't stop, couldn't stop the hallucinations and so on, and had to get hospitalized. And then later on ended up returning to these things, even though they had this very negative psychotic experience. And so just as an example, and then needing more substances to get the same effect. And this is known as tolerance, and then developing withdrawal symptoms, which can be relieved either by taking the substance or through other medical intervention. So as you can see, the criteria for substance use disorder, they're pretty discrete. And some of these things you may or may not know about initially when someone is coming into your office to work with you. But so knowing what use is that's problematic versus what's just kind of maintenance or typical daily use is also going to be informative for you in your work to know this. So the other thing to be aware of then is that as mental health practitioners, is many times we don't really know a lot about how the alcohol and drug field organizes their treatment strategy. So I just included a slide here to talk a little bit about the American Society of Addiction Medicine, which really looks at problem use behaviors across 6 dimensions. And in some communities, they add an additional dimension. I mentioned I used to work with the Native American community. They would internally to their programs, some of the programs would add a 7th dimension, which was really targeted towards spirituality and these factors, which is very important in that community. So anyways, what we do is we use these ASAM dimensions to create this holistic biopsychosocial assessment of individuals' use behaviors. And then we use that to really guide service planning across these dimensions. So the first is acute intoxication or withdrawal potential. So, someone is kind of a heavy, steady user, this becomes a very serious factor. And usually this is not something you're going to see in your outpatient clinic. This typically will involve medical monitoring, sometimes even hospitalization, stabilization, depending on the substances, particularly alcohol. Coming down of heavy sustained alcohol use is something that, as you know, you can lead to seizures and death and so on. But with substances like cannabis, you're going to see less of that. There is some exception to that for the extreme heavy user of cannabis who uses it pretty much throughout the day and uses it and uses the high THC content stuff, merchandise or product, whatever you want to call it, cannabis, they actually will have some physical withdrawal symptoms. But for the most part, you're not going to see that with that substance, particularly at low levels of use. You will see it with some others, such as amphetamines, you see with alcohol, as you mentioned, obviously heroin and the opioids. So those really need to be managed medically initially, or at least so supervised. And then what other biomedical conditions or complications contribute to this person's your use history? So, for example, are they having cannabis use on a regular basis because they struggle with sleep issues, insomnia? I hear that a lot. Or let's say, they become addicted to pain medicine because they have chronic pain issues, or they use cannabis for that same purpose. So these are some of the common explanations for use that people will bring in, is that it just they believe, at least it does has some biomedical assistance to them. And I think there's more research going on regarding that, particularly in the realm of cannabis, since it's so available, and people claim that it does help with certain medical issues that they have. And then the emotional, behavioral, or cognitive conditions that complicate their care. So, do they have very highly reactive PTSD responses, for example? That is one of the primary uses of substances, is to help kind of down-regulate or avoid or escape, just as one example. And then the readiness to change. This is something that's really grown into the field over the last, 30 years now. So it's not, I can't say it's new, it's been around for a while. But this is really looking at the change process, and I'll circle back to that in just a second, and how motivated somebody is to change. And then relapse or continued use or continued problem use potential. What is that for this individual? So some people believe that they can moderate, and they try, and then they repeatedly become dysregulated in the volume of their use. Others can't. So, but what's the reality of that? So you want to know that history, so you have an idea of how quickly their trajectory into problem use becomes. So if they're working with you on an outpatient basis, that you can talk openly about these things and monitor collaboratively and see how their use behavior may indeed become a part of an escalation process that they may be in denial about, or maybe they just haven't seen before because they've never truly examined it. And then what's the recovery and living environment? So are they surrounded by people who are really endorsing and supporting the maintenance and use of those behaviors? Do they have to be secret with other key people in their lives, such as their spouses, in order to maintain the behavior? Or are people encouraging them to really regulate themselves better, or to discontinue use because it's causing some of these problems that may be impacted across these other dimensions, whether it's family or work or health or whatnot. So knowing these dimensions is helpful. I would not anticipate the typical outpatient psychologist or counselor to use this format. These are built into most outpatient treatment programs. So for our purposes, what we're really looking at here for this discussion today is what's in this red circles, is what we would describe as kind of the early intervention outpatient services that most counselors would have. But knowing that ASAM, those 6 dimensions of ASAM, is really designed to help you determine, you basically gave them a score on a Likert scale, what level of intensity of care that they need in order to really stop substance use or reduce it significantly. And so all these, the right side of the continuum here, really starting with intensive outpatient care, is really going to be handled by most of the licensed alcohol and drug treatment entities. But, as an outpatient therapist, for example, you may find yourself coordinating with more intensive care that they may be receiving at some of these entities. And that's not an uncommon experience. Okay. So I mentioned this idea of readiness to change or receptiveness to care. And so I think it's worthwhile to spend a few minutes talking about the whole stages of change theory that was developed by Prochaska and DiClemente. And it's considered a trans-theoretical model, so it can apply to whether you're a behaviorist predominantly, or maybe you're more analytic in your theory and style of care or whatnot. And so the idea here is that before people change, they really approach they approach a problem from a place of really not being aware that maybe change is necessary. And we call that pre-contemplation, where when someone is in pre-contemplation, there's no intention on changing the behavior. Okay. When I used to work with adolescents, and part of what we would try to do is we would ask them, so, they come in for alcohol and drug treatment. And we say, well, so what brought you here today? Hoping they would say, well, I smoked too much pot and I'm failing school, and they would say, well, the bus brought me here, maybe kind of snarky. And for those of us who kind of knew that these kids were in a pre-contemplative stage, they didn't really see their heavy cannabis use and their school failure as having any relationship to each other. And truly, the only reason they're here is because the bus brought them. And so we would consider that pre-contemplation. And so the trick for the therapist, or the strategy for the therapist for people who are pre-contemplative, is just really to raise doubt. Okay, maybe something could be better. Okay, or different at least. And then when doubt happens and they begin to question, maybe something is worth looking at, then they enter into this contemplation phase. And this is where they become aware that a problem exists. Maybe aren't that committed to changing it. They're not committed to going forward or backwards. And sometimes people think about it and they leave contemplation, just go back to pre-contemplation. Okay. But at some point, the strategy for the therapist in the contemplation stage, is to increase the doubt. So the first strategy was raise doubt. Contemplation is you want to increase doubt and help them consider that alternatives actually might at least be as good as where they're coming from, and maybe not. And maybe perhaps even better. And typically what happens is when there's a point of crisis or decision that happens at the end of the contemplation bubble, as it were, where they decide to do something about it, okay? And so that leads them into the next stage of change, which is called preparation. And this is where you're really focusing on honing in on what intentions they have to implement to take action. Okay. So maybe this isn't action yet, but this is how do we plan that change? Okay. And what do I need to do to address the problem? Okay. And then we actually implement those changes. And this is really the action phase. It's called action phase of stages of change, where the trial and error occurs. So you did your planning, you implemented it, maybe you succeed, maybe you fail, you learn from the failures, and you modify your action plan and you implement it. So this is the meat and potatoes. And often what happens is folks come into care, whether it's mental health care or alcohol and drug care or whatever, and this in the olden days is they would be expected to get into action right away. And we would have skipped over all these other internal experiences the person was having. So they'd still be pre-contemplative, and we say, you need to change. And they'd say, thank you very much. And they'd leave, okay? So the actions were the nuts and bolts of changes. And then once it has occurred with some success, then you really move into the next phase of change where you maintain those gains, you kind of build up the architecture or the scaffolding of the positive behaviors that they've pursued, and the scaffolding to resist or remove the negative behaviors that have been problematic, and then they go ahead and leave that change cycle and carry on with their life. But things happen and people relapse, and we recognize that, and so then they perhaps re-enter that change cycle and consider things they hadn't considered before. And so the nice thing about the stages of change model is that you can apply it not only to substance use, but you can really apply this to many things in mental health care as well. Whether it is helping your bipolar patient accept that reducing their meds is not a good idea because they feel so good. They're feeling stable, right? That happens a fair amount too. So it really applies well. So anyways, so we have this normalization in society where these substances are more accessible. We're seeing that they're being integrated into research and particularly applied to mental health problems, that we have kind of some basic understanding of the criteria for when substance use becomes substance abuse, basically, or substance use problem behaviors, okay? And then we have some frameworks to be familiar with to understand where someone's use falls on the continuum of not only of a diagnostic category, but where that would apply them in the level of intensity of care that they would need to receive. And also an understanding of how motivation becomes a major player in helping people move forward with examining their substance use behaviors in the context of their mental health problems or other things going on. All right. So, so how has our interventions around substance abuse, evolved over time? So I call this the evolution or a philosophy of treatment. Okay, so there are three prominent models out there. There's the abstinence model, historical abstinence model that most people are going to be familiar with through 12-step concepts. 12-step models. Then there's this idea of harm reduction. Harm reduction models are, a best example of that might be needle exchange. Okay, and actually, as I mentioned, Oregon has moved over into decriminalization of low levels of substance possession, is that it is now embracing harm reduction as a legitimate approach. So instead of criminalizing it, what we're doing is we're saying, okay, this is an out of control behavior, psychosocial and emotional behavioral problem. Let's see if we can get you into care to reduce the harm that this out of control substance use is causing you and perhaps people you are in your world and society and so on. Okay. So for the abstinence model, I mentioned 12-step, but it's not exclusive to that. I mean, there's cognitive behavioral therapies that have been applied to implement that model as well. There's relapse prevention programs that are designed to help with that model as well. And so now what we're seeing is with the harm reduction coming in is we're seeing in many ways, but some people would argue more realistic and new attuned approach to substance use so that you can move them towards eventually an abstinence, a model of care if that is appropriate for them. So I mean, this is particularly something with the repeated users. And I don't know if folks are aware, but it takes on average for significant substance abuse users, basically, the average of interventions is 5. Okay, for people who require residential treatment, on the spectrum, as it were, on the standard distribution is the average number is 5. Okay, so hopefully people who are coming to our outpatient care with us aren't going to be on that more extreme end of the distribution where residential care is required. And then there are maintenance kind of types of models as well, where, for example, and methadone treatment is kind of one of those where it's really a hybrid of harm reduction and maintenance. So you go in, you maintain a certain level of medical stability by getting methadone so that you can then reintegrate into your life. It's harm reduction in the sense that you are trying to remove some of the social behaviors or substance use chasing behaviors that are interfering with your ability to just move forward with your life and stabilize it and get work and so on. So when we look at also the over time, substance use, at least in the 19th century, was really seen as a psychiatric / medical problem, okay? And it was handled through that mechanism. And then we saw the emergence of 12-step, which was in the early 20th century. And then over time, what we saw was the increased focus of using psychological concepts such as cognitive behavioral therapy in applying efforts to change substance use behavior. And then a motivational interviewing kind of grew out as a part of that as well, so that you were more strategic in the intensity of clinical focus. So you tried to align it with the motivational state to nurture them forward, kind of bringing Rogerian concepts back in. And then the adoption of harm reduction approaches as well, kind of integrating in some ways with some of these other models. And so now that we're seeing some more emerging research, revisiting some of these alternative methods that I've mentioned before. So in some ways, if they start, allowing the use of like MDMA, for example, in the care of mental health disorders, is that we're really seeing kind of a hybrid of, well, this is it's a psychiatric medical experience because we're bringing in pharmaceuticals. It's also a harm reduction approach in some ways because we're using pharmaceutically approved substances versus going out and doing it. And in some ways, it's also part of that 7th dimension I mentioned that some of the tribal programs use, where it's a bit of a spiritual approach. And so people who have gone through some of these therapy talk about having a spiritual experience. Some, not all of them, but some of them do, kind of a sense of unity with the world and universe and so on. And then there's also some cognitive reprocessing that occurs with this as well. And so part of the therapies include, doing a planning, and then what do you want to get out of this? It's more of an internal experience. And then they go through the application of the substance, the MDMA, for example, psilocybin. And then they have a series of those where they integrate and they process and try to kind of learn from that experience. And then they exit that model. So we're also seeing that the philosophy has pretty well become established as a biopsychosocial problem. That prior drug laws clumped everybody together, and this is changing as social acceptance of substance use has morphed. However, I must say that there's at higher levels of use, okay, or higher levels of criminality or criminogenic attitudes, they still saturate the more entrenched addiction culture. So this is, the substance user or abuser today, or the alcohol user today, we have a higher incidence of basically criminality in that group. And some of this maybe have been societal trends criminalizing it, which required criminal activity in order to use it. And but we do see that with the more entrenched addiction culture, that you do have some of those more criminogenic attitudes that impact our behavior choices. So then we also have recognized that the co-occurring mental health problems that are often present with addiction or addictive behaviors, as I mentioned earlier in those other slides, is depending on the condition and the circumstances, it can be as high as 50% almost, or at least 1 in 20 for most mood disorders. And so, but typically the mental health problems have often been under-identified and maybe not addressed on the addiction side of the world. I would argue that many mental health practitioners have not adequately addressed some of the substance use behaviors that many of the clients bring in. And I've been surprised just to learn how many have had kind of chronic use behaviors that they just never talked about until it became more normalized. So what we're seeing is less disruptive substance use patterns can be addressed in a least restrictive environment, therapeutic environment, and that's good news for practitioners. Before we defer to those more intensive levels of care, which may be appropriate, but they also tend to have a higher propensity to be more disruptive in their life. So what I've posted here is just kind of more of a quick snapshot is when you're working with folks who are using, and this is a Jellinek curve, which really applies to alcohol, and it grew out of some of the recovery literature, but I think it has application in other substance use behaviors as well. But the idea here is that the more you use a substance, and the more it becomes a part of your coping, your lifestyle really, and your coping strategies, is that as it increases, we see the kind of not degenerate, that's not the good word, not the word, but we see this kind of decline in functioning, psychological, emotional, social functioning. And so, and over time, what happens is as those behaviors of coping become more distinct and isolated around the substance use and pursuing it, maintaining it, and so on, is that at the bottom of this cycle of use is that you really get stuck in a pattern that is compulsive, it's repetitive, it's loss of control in essence. And so you can stay there quickly, or you can stay there for quite a long period of time. And the idea of the recovery model is that once you realize that you are out of control, which was acceptance, that you would then begin to dismantle the denial and the other defense mechanisms or compensatory behaviors that was allowing that loss of control use, and you come out of this dependency cycle, as it were, and get into early, mid, and late recovery. So, addiction is seen as early addiction, mid addiction, and late addiction. And by the time someone's in a late addiction, they're really in that loss of control at the bottom of the cycle here. But so I would, it's a nice tool just to have as a reference when you're working with your clients on an outpatient basis, and you know that they're using and they're sharing it with you. Having some behavioral correlates to loss of control are healthy anchors to use in your discussions and work with folks. Okay, so what to do as a general mental health practitioner when clients legally use substances as part of their lifestyle. Okay, so first, know that harm reduction is a valid intervention starting point, okay, based on your client's motivation to use or not use substances, okay? So if they insist on using, then you talk with them about, all right, let's work on not increasing it. Let's try to reduce it, but let's also evaluate how it is impacting or even impairing parts of your life. So we want to reduce the harm that it's having by examining its effects, okay? Approach their behaviors, your client's behaviors, as being on a continuum or a series of continuous behavioral manifestations of an increasingly growingly significant problem, okay? For example, like I referenced on the Jellinek curve, okay? What is their behavior on the continuum relative to the DSM criteria for substance use disorder? So, for example, are they spending more and more time going after the substance? Are they hiding it and being sneaky? Is their spouse commenting on their concerns about it? Are they lying, to their spouse about it? Are they missing work because of it? So on. Have friends commented on their use, and so on. Okay, and then so on that continuum, determine, is the behavior of substance use declining? Is it stable, maintaining, and is that agreed upon, or is that something that you want to work on? Okay, or is it escalating? And I find that having this kind of tiered dynamic approach of declining, stable, and escalating is a helpful way of dialoguing around someone's substance use behaviors as it applies to maybe something else that you're dealing with, such as anxiety or whatever, okay? And then monitor change on the continuum and then adjust your treatment accordingly. So if their substance use is steady or increasing or decreasing, heavy but decreasing, for example, how much time and energy are you going to want to put on that with them if you're dealing with something that maybe got them in the door, such as anxiety, but then you learn some of these other aspects of their substance use behavior, okay? So let me give you an example. An individual, a high-level, high-performing individual, works at the kind of the top of a corporate level, has been a cannabis user all his life, okay? But has kind of dialed it back as he's become more and more professional, right? Well, this person also has a very, I would say, the relationship with his family, his primary caregivers, mom, dad, okay, particularly mom, is fraught with a lot of attachment problems, okay? Very self-absorbed, narcissistic parent. This person's kind of coped with this all his life and recognizes that as a teenager, you know, partying and being stoned all the time was probably the best way to kind of manage and cope. And indeed, when this individual would visit with the family, and now as an adult, he could only tolerate being really kind of stoned, honestly, around the parent. So this person has this pattern of behavior and comes into therapy for anxiety, and then what happens is that behavior actually decreases. Okay, the substance use of cannabis decreases. You know, spouse was concerned about him doing it too much, so he dialed it back. He was able to maintain it at a low level and then resolve some issues and move on and feel pretty good. And then, unfortunately, the parent moved into the area, and this saw a direct correlation to a re-escalation of the substance use, which is now becoming a problem again and enough concern. Okay, so this is an example of somebody who had steady use, actually reduced use, was able to deal with some of the mental health concerns at the time and go on, you know, take a break, basically from treatment. Things changed in their life. Now the use started to escalate, but it was directly related to some of their internal anxieties and problems around dealing with, you know, parental issues, all the attachment stuff that came along with that, injuries that came along with that, and then not managing that well. And so re-entered care to address that and recognize that the substance use escalating was directly correlated to it. Okay, so this person doesn't need to go to outpatient treatment, but they do recognize that there is what is normal, acceptable use, and even a coordinated, agreed-upon use with their primary caregiver, who was just fine with, you know, doing a little bit in the evening every now and then, had become escalated and out of control, so that the sneaking behavior started to occur, started used during the workday and so on, and hiding it from his wife and so on. So that became a problem to deal with. So I'm sure others have probably experienced this in your own practices to some degree. Okay. So the clinical so what to do as a mental health practitioner when they legally use is that the clinical focus area, and this is a primary critical question, is what is this person's, at least that I would use, is what is this person's relationship between sustained subclinical substance use and the following, okay? And these are things we see all the time in our mental health care, right? So what's the relationship between their substance use and their emotional regulation or dysregulation capacity, okay, and or abilities, and then, but more so, their capacity to do it under whatever stress or duress they're under, okay? What's its relationship to trauma recovery, okay? Whether that's acute, discrete traumas, like, you know, something happened in a discrete window and that was like the only trauma they had, or they've been exposed to maybe the complex trauma, developmental trauma, these factors that have much more pervasive impacts. What's its relationship to their cognitive framework? So what are their beliefs and attitudes about it? Okay, what distortions do they have about it? Well, you know, denial, for example, it's not a problem, is a very important factor in many substance use behaviors that begin to lose control. Okay, and then what kind of interjects do they have about themselves and the substance use in their life? Okay, and so how much of it is a kind of a defining mechanism of who they are to maintain it? Okay, so these are all important questions that I think you would want to be able to kind of ask and pursue and explore in the course of your work, and some of these you can get through interviews, and some of these actually you can really pick up, and particularly over time with some of the testing measures that we used and that I used. I'll get back to you in a little bit. So what's its relationship to the family of origin issues and their attachment experiences, like the example I gave of the professional, or, you know, another individual who had lifelong experience of trauma, which I'll go over a case later of this person. You know, what's their substance use relationship to some of these other things. And then affective barriers such as bipolar disorder. And so, there's a high correlation of bipolar disorder and substance use, and we see it all the time in outpatient alcohol and drug treatment. It's kind of become one of the diagnosis du jour. You got PTSD, you got bipolar disorder, you got mood disorders. Those are the kind of the main three big ones for outpatient treatment for addictions. But as mental health providers, you will probably encounter some of this substance use with your bipolar individuals, and then as well as major depressive disorders and then other thought disorders. So for example, some substance use can really exacerbate more frank thought disorders, and we don't want to have that experience get out of control. Particularly if someone is using things like cocaine and they have a history of schizophrenia or paranoia. With the decriminalization, at least in Oregon, you can do methamphetamine, you can do cocaine, and if you happen to have a paranoid internal architecture, those are not going to be very, very good for you. Okay. Above and beyond it's other harm. So how do we then, I mentioned kind of how do we use testing, okay? How do we use targeted psychological testing to help influence our treatment emphasis? When substance use is a component of your client's behavior or potential behavior, okay? So, I like to use psychological tools, assessments, not always at the very beginning. Sometimes what I'll do is I would work with somebody, and then I would maybe bring in tools later on to get a better understanding of kind of some of the deeper, what I call the architecture of some of their issues are. And maybe it's just at that time as things escalate. But you can use it at the beginning, you can use it in the middle, and you can kind of use it for maintenance and tracking of care. It's a number of tools. But I like to use them to get greater insight into the underlying causes and dynamics that are contributing to treatment struggles. Okay, so the treatment struggles could be their mental health treatment struggles. So I use assessments to give me some clearer insight into what is perhaps driving some of their struggles. And maybe they circle around the same issue again and again. Okay, and what are the risks? I use them to also, for example, a risk could be suicidality. Okay, obvious one. Okay. I use them to identify cognitive functioning. So, for example, many folks who have ADD or ADHD, and I want to rule that in, are they having some processing impairments? And this is particularly the case for folks who maybe had a history of significant substance abuse. Now they've kind of stopped using, and they may be working with you in your clinics or in your counseling offices, but they have concerns about some of the information processing problems that maybe they had before they used, but maybe have been a consequence. And so pulling in some of the neurocognitive tools to assess for that is helpful. Some of the executive functioning tools, such as the Brown scales, are helpful, or the R-bands to get which is a kind of a rapid assessment. Battery of neurological symptoms. It's a very nice, quick down and dirty tool that you can use to get a snapshot of some of those cognitive functionings. I'm not going to show that here, but those are some I would typically pull in. You would use assessments to identify a range and depth of mental health issues, such as attention problems, maybe major affective disorders, or other mood disorders, dysthymia, for example, or major depression, anxiety disorders, whether it's general anxiety, social anxiety is very common in folks who have substance use issues. Believe it or not, it's one of the most undiagnosed co-occurring conditions in the field. But it has one of the highest levels of prevalence of the anxiety disorders where there's going to be co-occurrence. Social anxiety is typically one of the top ones, but people typically don't ask about it and they don't treat it very directly, unfortunately. And then also personality function. What kind of personality dynamics and factors go into fueling some of these behavior choices? Assessments, objective assessments also allow us to have a better understanding of what I like to describe as the black box. And the person's black box, what goes on inside, right? And their capacity to engage with you as a therapist, counselors or peers, and barriers that may come up in their processing of what they're going through because of some of these internal dynamics. And I'll give you an example of it. Also, the nice thing about assessment measures is they give you some, particularly the MMPI gives you some really targeted information around depression management. And this could be faking good, faking bad. It could be minimizing, avoiding. It could be saying, help, I'm a bit in crisis here. Okay. So the nice thing about tools that have these robust validity measures in them is they give you as an entry point, nuanced way of looking at how motivated is this person to be sharing information or sharing about themselves with me? How protected are they? How raw are they, perhaps? And so you can get some of this from interviews, but often you can get surprise from, or a confirmation at least, from using some of these objective measures. And then they allow us to assess what I describe as negative cognitive sets, or solidified introjects, nice fancy phrase there. So how are they basically internalizing the world, okay? And so the objective measures, particularly the ones where someone takes a test like an MMPI or a Moran test, where they're saying, well, this is kind of how I experience this question. They're sharing about their internal processes, and they're giving us some information about really how they metabolize the world, and how they internalize their interface with the world. Okay, and also then some secondary personality dynamics that might impact treatment. So, if someone has more of an entrenched personality disorder, particularly where, ego dystonic, which is basically, I don't see a problem with my behavior, it may be a large factor, that's going to impact the directness with which you maybe tackle certain behaviors, particularly substance use behaviors, that they may have accepted as ego syntonic with their life circumstances as being good for their life management and coping and whatnot. Okay, but it's important to be able to tap into that to understand how this impacts your treatment, and then to use them to track change over time. Okay, and so particularly the more rapid assessment tools where you hone in on things like depression and anxiety, which are the kind of the more immediate metabolization of people's distress, as it were, that can be reflected in those and captured by those tools. So here's the strategy that I would recommend, or like to just kind of throw out there, and is that clearly you want to establish a relationship with the client and get a thorough understanding of their history. Okay, so. And I say this, it's kind of a no-brainer, but it's really important that honesty around substance use behavior is essential in doing deeper work. And I think, I kind of said this earlier, I think a lot of people actually will probably, more so than maybe we knew, were doing cannabis, for example, on a fairly regular basis, but they just didn't talk about it. And I think the stigma has been removed to such a degree that people are more open and casual, really, about talking about ingesting it for help. I often hear to help as a sleep aid, to help them feel less anxious, and that may or may not be true. I mean, there's all kinds of pharmaceutical reasons why somebody would feel less anxious when they're on cannabis, but also some real contrary information that, data and research that actually says that it can escalate things like anxiety. So, the jury is still out because the research is now finally being able to get ramped up regarding some of the stuff. Okay. So I would, use objective assessments to give a greater understanding of the internal processes you will be or are addressing in your treatment. So this can be done throughout treatment, as I mentioned, when appropriate and as need arises. You want to determine your treatment focus. So what comes first? So reduce use, do we want to reverse demoralization? So maybe they're coming in, they're just suffering all over the place, and just honing right in on substance abuse right away is not going to be a good idea, because you really want to help them decrease just their psychic suffering. And maybe you put their 3 joints a day cannabis use to the side for a while and come back to that. Okay. Do you want to focus on mood enhancement? And so maybe there's interplay between their substance use becoming a deterrent mood enhancement, or maybe it's a supplement to it, but you want to figure that out. Anxiety reduction, family stresses, employment stuff. So hone in on your treatment. What comes first, but don't be afraid to say, okay, we're going to table certain things and deal with stabilizing your life and then moving into other things. So if and when you determine that substance use is a persistent factor, though, in their lifestyle behavior, then you really want to make sure that you are assessing the pattern and severity and assess the degree of harm it is potentially causing. Okay. And a part of that, and this is a part of what comes out of motivational interviewing, it's not only do you ask about the harm, but you're asking about the benefits they get from it, so that you can take a balanced approach to how you tackle this phenomenon in your treatment. And what will happen, by and large, is that over time, is that the clients that you work with, if you're comfortable talking about the pros and cons of all the stuff, is that they become more comfortable with the normalization of talking about it because it's a part of their life and not something that needs to be held in secrecy from you as a part of your work. And then you can work on it collaboratively if that's what you both decide to do. Okay. So if substance use is egosyntonic, which just means, it jives with kind of your worldview of things. If so, consider using motivational interviewing techniques to move to that contemplation stage, to raise doubt about sustained use if it's determined that it's causing them problems. So if you think that it's causing problems, but they think, well, it's good for me, it helps me, then your challenge is to help kind of raise that doubt and move them through that change cycle incrementally in order to address the behavior. Okay. All right. Continuing with the treatment strategies, you want to establish the role that the substance use plays in managing who they are, their self, their feelings, their memories, their stresses, and so on. So is it truly recreational? Okay. Is it primarily an avoidance behavior to self-medicate or self-soothe? Okay. Like this example I gave earlier. Is it primarily used for down-regulation, right? So up-regulation is you're stressed out, down-regulation is you're calm and tranquil. And so we might use terms such as subjective units of distress to kind of track that. So maybe a 10 is highly distressed and 0 is not distressed at all. And then I always find it's helpful to understand how their substance use is related to their attachment issues. Healthy attachments are, if you have a healthy attachment with your primary caregiver, that they're always going to be available. Generally they can soothe you. They help you feel good. They're reliable. Okay. And when you think about substance use, they're always available. Where to get them, how to get them. They're not hard to get. They're pretty predictable about how they help you feel, and often they help you feel differently and maybe even better sometimes. Okay. And so you can begin to see some of the parallels that particularly early substance use has with people who have had some rocky attachment experiences. And so, and often those are the ones I will see as wanting to maintain and sustain kind of a low level or moderate level of use in their lifestyle. Okay. So then proceed with psychotherapy, but continue to actively attend to those above factors. Okay. I just went over here. And then so then I already gave the case example is of a cannabis using professional. But, I'm going to talk about one who's PTSD, has significant PTSD, and has some concerns around substance use as well. Okay. But always, if the substance use is escalating out of control, then treatment focus should shift to getting a higher level of care following ASAM guidelines as appropriate. Okay. Motivational interviewing techniques may be more intensive required here as well. So, I can think of a client who I worked with for quite some period of time. And then it turns out one day he got fired from his job, and it turns out that the person was actually drinking for a year steady and was starting to drink at work and got caught and got fired. And so that immediately became a pivot point to focus on the substance use behavior. Particularly in this case, it was drinking, but that caused the immediate problem. But the individual also has kind of a lifelong substance use history of cannabis. So that becomes the focal point at this point, because the pain point has required a pivot for that individual to look at their sustained use is causing more issues. Okay. All right. So, I could share an example of how we can get a better understanding of someone's internal landscape using some of our tools, MAPI-2 RF specifically. The MAPI-3 is out, but the data was from a prior version. The MCMI-4, which is the Moran clinical inventory, and most recent edition, and then Beck, some of the Beck tests. Okay. So I like to use these tools to get an assessment of the degree of potential pathology, psychopathology, that's going to be a factor in this person's or individual's care, or that it is having as a factor if they're like an established patient. So maybe you bring this in, maybe not at the beginning, you bring it in later on because you have some pivot points maybe you need to hone in on. Okay. As well as the mental health drivers. And I call these the drivers. This is how they process the world, that is going to be captured, at least psychologically, emotionally, that are captured by these tools. And that contributes to their substance use dynamic. All right. And then assess the potential for impression management, minimization, fragility. Okay, are they in crisis? Okay, and then also to use tools to give me insight into how life experiences have been internalized and that now manifest in harmful beliefs, attitudes, projections, and interjects, view of themselves and others, psychic pain, and risks to health and risks to care. And then track and manage more acute manifestations of mood issues until they stabilize or decline. So these are kind of the general targeted reasons I would have my pool test in. So let's talk about a case that's a 52-year-old female. Now, this individual had come into actually alcohol and drug treatment years and years ago, okay, and came into treatment and was very, very dysregulated, emotionally and behaviorally dysregulated. What brought her in was alcohol use. At the time, and she would actually engage in treatment and then get too up-activated, too anxious, too wound up, and then she would have to take breaks basically from care and then come back in. And then this person was eventually referred to DBT, which helped teach some of the skills to self-soothe and downregulate and handle her distress and so on. But the history is that this person has a childhood sexual abuse history, she and some of her siblings, from multiple abusers growing up. Okay, her mom was associated with a biker gang and would just have men in and out all the time. Drugs were rampant, firearms were rampant, and just a woman's early life experiences. And in the course of her care, it was evident that she had an extremely poor attachment experience to her mother, her primary caregiver. Father was out of the picture, but a highly invalidating mother. And that persisted really throughout her life and probably continues to be so. But then, so she started developing substance use behaviors really in her early pre-adolescent years, okay, because of access and exposure and whatnot, and coping really. And then, as an adult, she suffered a very severe sexual assault. It was a brutal assault by multiple perpetrators that essentially left her for dead, and then she did die, obviously, and then later on, just lost herself in alcohol and substance abuse for a while until decided to get help. So then, she has a history of ritualized self-inflicted cutting to help cope and manage, and when I say ritualized, it wasn't something that was like, oh, I feel stressed out, I'm going to do this. She would plan it, and then she would engage in behavior. She went to outpatient care. She addressed complex trauma and treatment. But then with COVID-19 landing in this woman's world, it really increased her desperation. So her diagnoses, operating diagnoses, were PTSD, chronic. She also had some borderline features. Probably would meet criteria for borderline personality disorder at one point, but it's interesting that features are probably more appropriate today as her complex PTSD got managed. Depression, she has ADHD, history of that, takes medicine for that, and then has over 10 years of sobriety from alcohol, but then started using cannabis within the last year because of the COVID pandemic and anxiety and sleep problems. So this individual took the MMPI. Here's a kind of snapshot of the face page. I have the MMPI. Oops. Uh-oh. Sorry. I'm hitting the wrong buttons here, folks. All right. So this is somebody who had already been in care, was having an escalation in distress, took the MMPI, and this is the profile that was provided. So it was compared to outpatient sample, women's outpatient sample. And as you can see, these are the validity scales for the MMPI, which can give some indication of depression management. Now, by and large, most of the validity scales fall within the range that's typically seen in outpatient treatment. Okay, we have some exceptions, and one of those is the highest is the FBS scale, which is the symptom validity scale. This used to be called fake bad. Okay, kind of think of this as the old fake bad scale, right? Where someone who is wanting to say, "Hey, I'm in distress," or is trying to fake, could elevate the scale and be noted for that. Also, the trend scale, which is the true response inconsistency scale, was also elevated. But then when you look at the FPR, FS scales, those are all, well, they're elevated, they're clinical. They're telling us there is distress, but they are also within the range. So when I look at this profile, knowing, this is an example, I think, of when you know somebody and then you get a profile of them, it's always interesting to interpret it. This is somebody who I'd say is not an invalid profile. It is somebody who I'd say is saying, hey, I am really in distress, and it's showing up on their validity scales. So this was determined to be a valid profile. And then as we kind of march forward through the protocol here, is we see that her higher order MMPI scales, that she really is telling us that she has experiencing a lot of emotional internalizing dysfunction. And this is consistent with her profile, and particularly given her history, okay? So when she gets activated, she does a lot of internal negative self-talk. She's really kind of very hard on herself, okay? And then we see that her RCD scale, which is the highest of her restructured clinical scales, is elevated at T-score of about 70, followed closely by her antisocial behavior, okay? The antisocial, she tends to think out of the box and behave out of the box in many ways. Although this individual is not engaging in antisocial behavior, she tends to really challenge norms and whatnot, and has a history of that in her adolescence. But what this is telling us is that she is feeling a lot of psychic distress by that elevation in her RCD scales. And then is also elevated in her dysfunctional negative emotions, which is her telling us that I'm having a lot of anxiety, which would be consistent with what she's presented in a clinical setting. And then when we look at her somatic cognitive domain, we see that she shows elevation in having GI complaints. So a lot of her anxiety is manifesting as somatic GI complaints, as well as just malaise, where she has just had a sapping of her energy, will sleep a lot and knows it and talks about it and knows it's a problem. And then, as we noted, her higher order scale of internalizing distress is really manifesting. Of the 9 clinical scales, we see that she's elevated in 5 across this internalizing domain, with the 2 highest of anxiety and suicidal ideation. Okay, so thinking about rather be dead. Okay, and then we also see how escalation on her high levels of self-doubt. We see her stress and worry is elevated, and that her behavior restricting fears. So this is a person who's afraid to go out for good reason because of COVID, but is having a lot of anxiety and a lot of distress and suffering from it, and is really thinking about death a lot. Okay. And then when we look at the externalizing domain, she's not clinically elevated there. So most of this is, she's not acting it out, but she's acting it in. And then familial problems is very consistent with her reporting her dysfunction in her family of origin issues. I realized I was forgetting to forward my slides when I was talking. So sorry about that, folks. Let me just reiterate. She had high scores of gastrointestinal. And then she also had very high scores on the internalizing scale. So of the 9, the top 5 that she was experiencing distress were the suicide ideation, the anxiety, the FSD, which is the self-doubt scale, and then her stress and worry scale, and then her behavior restricting fears. So this is a profile of a woman who's saying, I am suffering, okay? And her self-response is consistent with that. And then, as I mentioned, the somatic complaints on her mixed. So then, as I mentioned, the externalizing scales, she's subclinical, but somewhat elevated. And the juvenile conduct problems, but we're not going to worry about that. She's 52. And then her familial conflict is very high, and that's really consistent with her reporting of some real attachment problems with her primary caregiver throughout her life. And then when you look at the sci-fi scales, she is clinically elevated. These are the personality scales for kind of a negative emotionality, neuroticism. So this is a profile of a woman who's really has a lot of internal pain and anguish. And so, but given her attachment history, I always like to find out what are some of the ripple effects. And I think the MCMI does a good job of kind of capturing how someone internalizes their kind of life experience, particularly if they have known conflicts with primary caregivers in their attachment years, so and throughout their life. So the MCMI I was given, MCMI-4, and the MCMI gives you a nice summary of interpretive conditions and things to focus on. I'm going to skip over that real quick, though, and just show you her profile. And so what we see is that, consistent with the MMPI validity scales, is that we are seeing someone who's sharing that she is having a high level of debasement, which means I am suffering. Basically, I'm telling you I am having problems, okay? As well as a high level of disclosure. So that she's really saying, I'm having a problem I'm feeling that I'm having a lot of problems, and it's across many domains. And so then as we kind of scroll down on this profile, and this is all, by the way, written in a nice narrative for you when you use the MCMI, as we can see that on her her main clinical personality patterns, that she has personality types loading for dependent and melancholic, okay, types, and she's elevated across a lot of styles that are generally seen as internalizing styles. But she's showing us that she has a personality type that is kind of doomy, okay, and dark. When we then look at her more frank psychopathology, we are very clearly getting indication of major depression, as well as post-traumatic stress disorder, and then generalized anxiety disorder. And I would say that these all fit very well with kind of the profile that she has presented herself with over the years. When we continue on with the facet scales for personality, is that we see what really jumps out is under that, remember we said we had a melancholic type, is that we see that she really has a temperamentally woeful disposition. It's like, I just suffer a lot. Things never seem to get better. I suffer and I know it, I feel it, and it's probably evident to others, okay? That she's cognitively fatalistic, that things never seem to get better, it just keeps coming, and that she has a kind of a very low self-image, kind of a worthless self-image. So these are the main drivers of her her melancholic, her type, her style, as well as dependent. Her dependent type is well, which is really driven predominantly by kind of the expressively puerile. And puerile is, if you're not familiar with the term, it means excessively childish and trivial. So you can really get caught up in acting somewhat childlike in the context of her relationships, very dependent, okay, for care. So because she has this melancholic style, we saw some elevation in her demoralization and her anxiety scales. So I wanted to get an understanding of kind of what's going on. So gave her the BDI, Depression Inventory, and as you can see, it was registered as very high, and particularly because one of her scores, she said, I would like to kill myself. We'd like to see a 0 on this, but she gave a moderate elevation on that, which is immediately going to escalate it to potential for concern, okay? All right, so we know that she's saying that I am depressed, and she's telling us and showing us she's depressed, okay? And then when we look at some of her critical items on the BDI, we see that she's sharing as severe, scores very high. I'm so sad or unhappy that I can't stand it. I feel my future is hopeless and will only get worse. I can't get any pleasure from things I used to, and so on. So, but what she scored at the moderate levels, I would like to kill myself. So this is going to raise, obviously, a red flag. While this person has a history of cutting behavior, she's never had an active attempt to kill herself. So we're going to want to figure out what's going on with that. Okay, so hopelessness is the hopelessness scale is something that I would then follow up with whenever I hear someone has either suicide ideation. I want to assess their level of hopelessness, because depression in and of itself does not necessarily predict suicide actions, but hopelessness does. When we see her hopelessness, we also see she's highly elevated on her hopelessness scale. So here's someone who's saying she's melancholic, she's suffering, she's in pain, she's saying, I'm thinking about dying. Yeah, I even think about killing myself sometimes. Okay, so now I'm like, really concerned. Okay. So then, as you can see on the hopelessness scale, it will also give you those items that she endorses true. So, for example, my future seems dark to me. Things just don't work out the way I want them to. That's that fatalistic view. The future seems vague and uncertain, you know, in the context of what our society's been going through. That's probably loading that as well with COVID. So then gave her the Beck suicide scale to see, because I have two kind of risk factors now. She's depressed. She's saying I have a lot of hopelessness. Oops, sorry. I had a little thing pop up here. How do I get out of that? Uh-oh. Sorry, folks. Slides. All right. I had it pop up. So I'm gonna see if this active suicidal ideation or is it passive. So when I give the suicide ideation, you know, measure of the Beck scale, we see that actually she says my risk of actual suicide is low. Okay, so is she being is she not being honest? Probably she is being honest, because she has been actually saying I'm having a lot of pain and suffering, but following up in conversation, she said, she confirms that she's actually not actively suicidal. That sometimes I think I'd be better off dead. If a bus hit me, it wouldn't be a bad thing. So, you know, that's the nature of her ideation. And and so moving ahead in care with her, it was determined that she was not actively suicidal, but clearly monitoring her depression and hopelessness are going to be an ongoing focus. So client treatment risk factors and considerations under the new normal is, you know, this profile I just showed you is this individual has started to use cannabis to help her sleep because her PTSD, flashbacks, and nightmares has been reactivated as really in response to some of the stresses and anxieties of COVID, living under COVID. So that's a factor now that is a concern, because it's a step towards reusing possibly alcohol, which was a major detriment in her life, much more so than her cannabis use was. But she uses predominantly a CBD-based product, which is supposedly not having the psychoactive effects that a more THC rich compound would have. So got to track that and monitor that. All right, so things to be aware of with the new normal is exacerbation or reactivation of PTSD-related symptoms, including the nightmares. I mentioned that the down-regulation skills were faltering, seeking external agents like the cannabis, which I mentioned, that cross-addiction to alcohol, eating, and cutting is a real risk for this individual, which although eating has become a problem, but everything else hasn't. History of escalation of behavior dysregulation when drinking, so we want to make sure that person doesn't go down that avenue. They've been overeating, as I mentioned, and they're feeling highly demoralized. So care is going to focus on that. So the intervention is targeted focus on distress tolerance and emotional regulation skills that she had learned in DBT, track acuteness of depression and monitor with the BDI-2. Okay. Track her hopelessness ideation and monitor with the BHS-2, and then monitor with suicidal ideation or being dead. Then use active cognitive behavioral therapy and with the targeted cognitive restructuring, that's restructuring, not restricting, to focus on decreasing hopelessness and demoralization and attend to her active PTSD due to a sense of powerlessness and isolation, considering doing EMDR at some point, referring that person to EMDR. Attend to an increase in cross-addiction behaviors and focus on utilizing healthier options, so not eating, overeating, or the ritualized cutting, which was a kind of an addiction for her. And like I mentioned, refer maybe for EMDR. And footnote is this client is in the Northwest and is really curious about psilocybin treatment in the future and would like to be referred to that when that becomes legally available. Thank you very much. I don't think I have any time for questions, unfortunately, but feel free to send me inquiry in the emails, and then I'll get back to you as soon as I can. All right. Thank you very much. Everybody stay safe, and until next time.